Welcome to the presentation. The topic is Approach to Dementia. What is dementia? Dementia is a general medical term. It is used to describe a group of symptoms caused by problems affecting the brain. In dementia, a person gradually loses important mental abilities such as memory, thinking, understanding, judgment, language, and behavior. These problems become severe enough to interfere with daily life activities like cooking, shopping, paying bills, driving, managing medicines, and even personal care. It's not a single disease, it's a syndrome, meaning it's a collection of symptoms that can occur due to many different diseases affecting the brain. The common causes are neurodegenerative diseases, especially Alzheimer's disease. For a person to be diagnosed with dementia, there must be a decline from their previous level of functioning. For example, if a person was previously independent and mentally active, but later develops memory loss and cannot manage normal activities, this suggests that there is dementia. This helps the doctor to distinguish dementia from developmental intellectual disability, which will be present since childhood. Difference between dementia and delirium. Delirium is a sudden change in mental status with confusion, altered mental status, fluctuating attention. It usually develops over hours to days and may occur due to infections, medications, metabolic problems, and other acute illnesses. In contrast, dementia usually develops slowly over months or years. However, people with dementia are more likely to develop delirium during an acute illness or hospitalization. The modern diagnostic system called DSM-5 uses the term major neurocognitive disorder instead of dementia. The milder stage is called mild neurocognitive disorder, which is similar to mild cognitive impairment. Epidemiology. Dementia is a major global health problem. Millions of patients around the world are affected. Number of cases are increasing with age. Older adults above 65 years are at much higher risk and prevalence rises sharply after 70 years of age. Research studies suggest that number of people living with dementia is increasing because people are living much longer. However, some studies from countries such as Netherlands, United Kingdom, and United States show that the incidence may be slightly decreasing in recent years. The important reason may be better control of vascular risk factors like hypertension, diabetes, smoking, high cholesterol. Causes of dementia. Common causes include neurodegenerative diseases, stroke and vascular disease, brain injury or trauma, infections, metabolic disorders, autoimmune diseases, toxic or drug-related causes. The most common cause is Alzheimer's disease. Other important causes include frontotemporal dementia, dementia with Lewy bodies, vascular dementia. Many patients actually have more than one brain pathology at the same time. For example, a person may have both Alzheimer pathology and vascular disease together. Diagnostic approach to dementia. Diagnosing dementia requires a detailed evaluation using history, examination, cognitive testing, lab investigations, and brain imaging. History taking in dementia. History is the most important part of diagnosing dementia. Doctor should speak not only with the patient but also with the family members or caregivers because patients may not recognize their own memory problems. Important points in history include first symptom noticed, mode of onset of symptoms, duration of symptoms, speed of progression of symptoms, effect of daily activities. Neurodegenerative dementias usually begin slowly and worsen gradually over years. Sudden onset suggests other causes like stroke, infection, medications, or psychological stress. Some patients develop symptoms over weeks to months. This is called subacute dementia and may suggest serious conditions like autoimmune encephalitis or prion diseases. Assess activities of daily living such as managing money, shopping, cooking, taking medicines, using transport, personal hygiene. Loss of independence strongly suggests that there is dementia. Key parts of the history taking. Coming to cognitive symptoms. 1. Impaired recent memory. There is repetitive questioning, repetitive statements, forget appointments, loses items easily. 2. Language difficulty. There is trouble understanding others, trouble finding getting words out, trouble finding words, using incorrect words. 3. Visual spatial difficulty, getting lost more easily, trouble reading, difficulty recognizing familiar people. Fourth one, executive or attentional dysfunction, that is poor judgment, difficulty in problem solving, difficulty maintaining focus, trouble with calculations. The motor symptoms can be presence of tremor or myoclonus, trouble swallowing or slurred speech, change in gait or falls, muscle cramp atrophy, fasciculations. Autonomic symptoms are bowel and bladder symptoms, presence of orthostasis, sexual dysfunction, that is erectile dysfunction, change in sweating. Sleep complaints are presence of REM sleep behavioral disorders, excessive daytime sleepiness, evidence of sleep apnea like snoring, stopped breathing during sleep, evidence of stridor. Behavioral symptoms are change in personality, socially inappropriate behavior, loss of empathy or interest in hobbies, loss of interest in family, compulsive behaviors, change in dietary preferences, disheveled, decreased interest in hygiene. Typical clinical patterns. Different dementias have different patterns of symptoms. Alzheimer's disease, the most common presentation is progressive memory loss initially. Recent memory becomes affected. Later, language, judgment, orientation, and daily functioning decline. Frontotemporal dementia. Patients may first develop personality change, inappropriate behavior, emotional change, and language difficulty, while memory remains relatively preserved early in the disease. Dementia with Lewy bodies. Typical features include Parkinsonism, visual hallucinations, fluctuating alertness, REM sleep behavioral disorder. Vascular cognitive impairment. This may occur after strokes or due to small vessel disease. Patients often show slowed thinking, poor attention, executive dysfunction, gait difficulty. Medical history. Past medical history can provide important clues like head injury, stroke, hypertension, diabetes, high cholesterol, smoking, heart diseases. Others are cancer, autoimmune disorders, seizures, meningitis or encephalitis, depression, sleep disorders. Repeated head injuries may lead to chronic traumatic encephalopathy, especially in athletes and military personnel. Family history. A detailed family history is important because some dementias have genetic causes. A doctor should ask whether relatives had dementia, Parkinson's disease, psychiatric illness, motor neuron disease. Sometimes family members have different symptoms from the same genetic mutation. Medication history. Many medicines can worsen memory or mimic dementia, like anticholinergic drugs, sedatives, benzodiazepines, sleeping tablets, opioids, muscle relaxants. If symptoms begin after starting a medication, doctor may consider reducing or stopping the drug. Partial list of medications which can cause cognitive impairment. First, sleep aids, cold medications, antihistamines with an anticholinergic component. Dimenhydramine acetaminophen, dextromethorphan, doxylamine, succinate, ibuprofen, diphenhydramine. Antihypertensives like beta blockers. Antidepressants, amitriptyline, anticholinergic property. Imipramine, anticholinergic property. Opiates, oxycodone, morphine, hydrocodone, fentanyl, propoxyphene, methadone. Benzodiazepines, alprazolam, clonazepam, lorazepam, diazepam, temazepam. Anticonvulsants, lamotrigine, phenobarbital, phenytoin, levetiracetam, topiramate, zonisamide. Anticholinergic drugs, tolterodine, oxybutynin. Antipsychotics, quetiapine, olanzapine, risperidone, aripiprazole. Hypnotics, zolpidem, esopiclone. Antibiotics, metronidazole, cefepime. Anticholinergics, benztropine, meclizine, scopolamine. Muscle relaxants, baclofen. Cardiac drugs, digoxin. Immunosuppressants, tacrolimus, cyclosporine. Mood stabilizer, lithium. Neuropsychiatric symptoms. Psychiatric symptoms are common in dementia and can help identify the type of dementia. Depression, anxiety, mania, personality change are the psychiatric symptoms. Other psychiatric symptoms are hallucinations, delusions, agitation, apathy, and obsessive behavior. Depression is especially important because it is common and treatable. Depression may resemble dementia, but dementia and depression can also occur together. Hallucinations are more suggestive of dementia with Lewy bodies, while personality change strongly suggests frontotemporal dementia. Cognitive assessment. Use mental status test to assess the memory and thinking ability. The common screening tests include Mini Mental Status Examination (MMSE), Montreal Cognitive Assessment (MoCA), Short Test of Mental Status (STMS). Coming to Mini Mental State Examination (MMSE), MMSE is a 30-point bedside cognitive screening tool commonly used to evaluate dementia. The domains tested are orientation, registration, attention, recall, language, and the total score is 30. Orientation is given a score of 10, registration 3, attention 5, recall 3, language 9, total of 30. Coming to orientation, it is given 10 marks. First, orientation to the time. We should ask what is the year, what season is this, what month is this, what today's date, what day is today, and 1 mark is given for each right answer. Orientation to the place, 5 marks. We should ask which country are we in, which state, which city or town, which hospital or building, which floor, room or the ward. Each question gets 1 mark. Registration, it is given 3 marks. We should say clearly, I am going to name 3 objects and repeat them after me. The 3 objects can be example, apple, table, penny. 1 mark for each correctly repeated word is given. We should repeat the objects until patient learns them, and we should score only the first attempt given by the patient. The maximum score is 3. Attention and calculation is given 5 marks. Option A, you can do serial sevens test. Here, ask the patient to subtract 7 from 100 repeatedly, like 100 minus 7, 93, 93 minus 7, 86, 86 minus 7, 79, 79 minus 7, 72, 72 minus 7, 65. 1 mark for each correct answer is given. Or we can try option B, that is word backwards. We should ask the patient to spell word backwards. Then spell backward DLROW. 1 mark each letter is given. The maximum marks given is 5. Recall 3 marks. After few minutes, ask what were the 3 words I told you earlier. 1 mark each is given and maximum score is 3. Language and praxis. Here, first one, naming. It's given 2 marks. Show common objects like watch and pen and ask them to name. 1 mark is given for each question. Repetition, 1 mark. Ask the patient to repeat without using no if, ands and buts. Option C, 3-stage command given 3 marks. Give paper and say, take this paper in your right hand, fold it in half, place it on the floor. 1 mark each is given for each command. Reading, 1 mark. Show written instructions. Close your eyes. Example, patient should read and obey the command. E. Writing, 1 mark. Ask, please write a sentence. Sentence should contain a subject, verb and it should make sense. F. Copying the design, 1 mark. Ask the patient to copy intersecting pentagons. We should look for correct intersections. All angles are present or not. The score and its interpretation: 25 to 30 normal cognition, 21 to 24 mild cognitive impairment, 10 to 20 moderate dementia, less than 10 severe dementia. Features in Alzheimer's disease. Typical deficits are involving orientation, delayed recall, attention, visuospatial copying. Features in frontotemporal dementia are MMSE may remain relatively preserved early in the disease because memory and orientation are less affected initially. Executive functions are not adequately tested. MoCA and frontal assessment battery may be more sensitive in identifying frontotemporal dementia. Here we can see mini mental status examination assessment table. Neurological examination. Physical and neurological examinations are important. Early Alzheimer disease may have a normal neurological examination, but abnormality may suggest other disorders. Important findings like Parkinsonism suggest DLB, focal weakness or asymmetry suggest stroke, peripheral neuropathy suggest metabolic disease, fasciculations suggest motor neuron disease, gait abnormality suggest vascular disease or normal pressure hydrocephalus. Laboratory evaluation. Routine blood tests are performed to identify reversible causes of cognitive decline. The common tests include vitamin B12 level, thyroid function test, complete blood count, blood sugars, electrolytes, liver function test, kidney function test. Vitamin B12 deficiency and hypothyroidism are important because treatment may improve the symptoms of cognition. Additional tests are done in special situations such as younger age, rapidly progressive dementia, seizure, cancer history, autoimmune disease, infection suspicion. CSF examination may help diagnose infections, autoimmune diseases, or Alzheimer's biomarker. EEG in dementia. Routine EEG is not usually necessary in dementia evaluation. However, EEG may help in if there is seizure disorder, rapidly progressive dementia, transient epileptic amnesia, suspected Creutzfeldt-Jakob disease. Neuroimaging. Brain imaging is very important in dementia evaluation. The common imaging methods are CT and MRI. These tests help identify treatable conditions such as brain tumors, subdural hematomas, hydrocephalus, stroke. MRI can also show pattern of brain atrophy that helps diagnose specific dementias. Advanced imaging like amyloid PET scans may help identify Alzheimer's pathology in selected patients. DSM-5 classification. DSM-5 uses two important terms. One, mild neurocognitive disorder. This is measurable cognitive decline, but daily activities are still mostly independent. Second one, major neurocognitive disorder. There is significant cognitive decline, severe enough to interfere with the daily functioning. This is equivalent to dementia. DSM-5 recommends two steps. One, Identification of the syndrome, mild or major neurocognitive disorder, identifying the underlying cause. Summary: dementia is a progressive decline in memory and other cognitive abilities, severe enough to affect daily life. It is usually caused by neurodegenerative diseases, especially Alzheimer's disease, but vascular disease, trauma, infection, and other disorders can also cause dementia. Diagnosis depends mainly on careful history, cognitive testing, neurological examination, laboratory evaluation, and brain imaging. Early recognition is important because some causes are treatable and supportive care can improve the quality of life.